Hello, my name is Kevin Fernando. I'm a GP partner at North Berwick Health Centre near Edinburgh and also Education Director of GP Notebook Education. In this episode of GP Notebook TV, I'm going to discuss abdominal aortic aneurysm, focusing on the guideline published by NICE during March 2020 on the diagnosis and management of abdominal aortic aneurysm. Now, by way of background, AAA has a prevalence of around 4% in men aged 65 to 74 years of age, with a 6-to-1 male to female preponderance. Acute rupture of AAA tragically has around a 90% mortality rate in the community and accounts for around 2% of deaths in men aged over 65 years of age. The main risk factors for AAA are smoking, hypertension and a family history of AAA. So with respect to this family history, if a man has an affected first-degree relative, his risk of AAA increases 4 to 10-fold. So what are the key take-home messages from this NICE guideline? Well, NICE remind us we should inform all men aged 66 years or over who have not already been screened about the NHS abdominal aortic aneurysm screening program and advise them, of course, they can self-refer. We need to particularly encourage men aged 66 years or over to self-refer to the NHS AAA screening program if they have specific risk factors, including COPD, coronary artery disease, cerebrovascular disease, peripheral arterial disease, a family history of AAA as already discussed, hyperlipidemia, hypertension, and if they're a current smoker or an ex-smoker. And NICE also remind us that our patients of European descent are at higher risk of abdominal aortic aneurysm. So, who should we refer to our vascular colleagues? Well, NICE tell us we should refer people with a AAA that is 5.5 centimetres or larger to our local vascular service to be seen within 2 weeks. Now, I appreciate, given the very challenging circumstances we find ourselves working in with the COVID-19 pandemic, this may well not be possible. For a AAA that is 3 centimetres to 5.4 centimetres, again, we refer locally to vascular, but within a 12-week window. And if we do incidentally find a pulsatile mass on abdominal examination suspicious of a AAA, then of course we should refer for ultrasound assessment. NICE also give us some stark reminders on when we should consider the possibility of a ruptured AAA. We should consider the possibility of a ruptured AAA in anyone with new onset abdominal or back pain. We should also consider the possibility of a ruptured AAA in anyone who has collapsed and we think there may be a cardiovascular cause underlying or any unexplained loss of consciousness. And of course, the diagnosis of a ruptured AAA is more likely in the presence of specific risk factors such as, of course, an existing diagnosis of AAA, aged over 60, a current smoker or a past smoker, and anyone with a background of hypertension. NICE also remind us that we should be given adequate information to people living with a diagnosis of AAA. We should tell them what a AAA is and reassure them that the majority of AAAs do not cause any trouble. However, we should warn them about the significant implications of a ruptured AAA. We should also discuss that AAAs tend to get larger over time, and it is these larger ones, unfortunately, that are more likely to rupture. It's very important we also discuss this family history as well, so men can tell their close relatives, their first-degree relatives, about their increased risk, and they themselves may require assessment. We should also discuss and assess cardiovascular risk in anyone living with a diagnosis of AAA. We can use cardiovascular risk calculators such as QRisk3 to calculate 10-year cardiovascular risk, and we can consider interventions such as statins to reduce that 10-year or lifetime cardiovascular risk. For our patients with a diagnosis of AAA who continue to smoke, we should directly offer them referral to a stop smoking service to reduce their future lifetime cardiovascular risk. And finally, for anyone with a diagnosis of AAA and a background of hypertension, we should treat them according to the recently updated NICE hypertension guideline published during August 2019, NICE NG156. We should aim for a clinic or office blood pressure of less than 140/90 millimeters of mercury, or an ambulatory or home blood pressure monitoring daytime average of less than 135/85 millimeters of mercury. And finally, very usefully, NICE signpost us towards the Circulation Foundation, a vascular charity with a whole host of very helpful information for patients with all sorts of vascular conditions, including abdominal aortic aneurysm. So well worth having a look at ourselves, but also signposting individuals with a diagnosis of AAA to the Circulation Foundation. So thanks for listening, everyone. I hope you found this episode helpful.